Yeah, so Sarfaraz had asked me, I think a month or so ago, and I totally forgot about it until I saw his messages yesterday. So I was like, yeah, I can speak on it. So I'm not going to talk about whys. We can talk about it after the talk. So I'm just going to talk about what could be done with the robot. And so let's get into it next here. So disclosures. So I trained for Intuitive, but also, I have gone through open, mini hemisternotomy, and then, I've done probably, I would say, 3 dozen or so robotic AVRs. And last year when I was here, I saw Dr. Knight's talk, and I was like, this is very intriguing, very simplistic, because my memory of MIS has always been very difficult, neck pain, back pain, elbow pain, all over the place. So I actually, just because I'm do like mitrals, TCABs, and trying to protect my robot time, so I'm actually doing a lot more. I've done probably, I would say, last 6 months, at least 2 dozen mini AVRs now. And so I always, it's like AVRs to get like low priority on the robot block, unfortunately, just because mini AVR is such a beautiful operation. But today's talk, so this is my approach. This is for both mitrals and aortics. The incision is a little bigger for the aortic because of all the sutures that are coming out. With mitral valve repair, you don't need that much of a suture management, but it is a very lateral thoracotomy. And you can do all sorts of operation with this. So I'm just going to present 2 cases. This is the sample case, as Dr. Amlavi said, intermediate risk, tower consult, not a candidate because annulus is small. What do you do? So this is 18 millimeter, and her BSA was, I think, like a little over 2.1, 2.2. And the question was, do you just put a small tower in or offer a minimally invasive operation? So so this is her echo, severe AS, very small root, small LVOT. I believe this video keeps on playing. So she had apparently prior pericarditis. So I decided to do a robotic root enlargement. The incision is exactly the same. And for robotic or RAVRs, robotic AVRs, we do make a vertical portion of, it's a hockey stick, but the vertical portion is a lot longer than the transverse portion of the incision so that you can actually look down. So this is the same video that you saw, is just different tools cut into the commissure between the non and the left. You can see the left coronary, I'm under it. There's a bit of calcium there in the LVOT. And obviously the trick is you have to go down to the naders, otherwise you can't really enlarge the root. It's a 2-minute video. It was, so it won't take long. Just need a few sips of Red Bull here to get a little faster. All right. We really take your time to get into the nadir there. I use bovine pericardium because it's not rigid. It just falls away from me when I want to. Otherwise, I've used Dacron sheet, and it's in my view. I usually start at the corner right under the left coronary because now that I know that I've secured that corner very well. That's the hardest corner to see when you look from outside. And I just take a 5/4 Prolene on C1 needle and I just run it up as far as I can. You can see it's awfully close to the left coronary. So for this one, I would put my aortic sutures not on that line, but a little into the patch. So to make sure that I have a big enough sinus for the left coronary to perfuse. It was a really small, this is a phenotype that we often see with the hypoplastic roots, very small annulus, very small aortic root. Almost running out of the suture there, so I'll just go as far as I can and then just tie it. And I'll take the other needle and then do the base of that Boyang. It's a rectangular patch. And the one thing that I've done even in open cases is I try to create some pleats into it so that the LVOT is a little wider and then the aortic sinuses get a little wider. You'll see I will fold it just a little bit. Bites on the patch are slightly wider than the bites in the aorta. I don't know if that makes sense, but. And then go all the way to that nadir of non-coronary sinus. Very important to have a really good assistant who can keep tension on the suture. You don't want to just lose. You can see this fold up here that will be tacked up with my valve sutures. It is as painful as it looks. And these are the valve sutures. So I will, as I said, I made suture away from that suture line between the left and the patch, and put these sutures on the patch to stay away from the left main. But the rest of the operation is exactly the same as you would do in an open or mini AVR setting. So I just stay outside and through the patch there. And this is where that fold, I will just tuck it in with my suture so it doesn't leak. And once the valve is seated, use core nuts for that. And close the aorta with a patch. Yeah, yes, the 5 foot goes all the way. And actually, usually, when I'm done sewing the patch, I come from the other side.
What size valve would you get?
Yeah, so I couldn't even get a 19 sizer in. This was a 23 valve. Yeah, 2 sizes up. And it all looks beaten up because she had prior pericarditis. That was a surprise to me. So I had a lot of adhesions to deal with. This is post-op echo. You can see the valve is opening. So next case, this is a 46-year-old gentleman with severe AI, severe AS, with LV dysfunction. Hasn't seen a doctor in years. Thought he was healthy until he couldn't breathe anymore. But we had this incidental finding. He had this aneurysm in the membranous portion of his interventricular septum. You can see here pouching into the right ventricle. And I'm going to play the CT scan one picture at a time. Let's see if it works. So right there. So I wish I had those 3D recons. But here you can see the pouch coming in and out here. So same approach, very lateral mini thoracotomy. And this is just slightly transverse on the right side, but then goes straight down into the middle of non-coronary sinus. It gives you a really good view. And this is a bicuspid valve, comes out in one piece with the robot. It works great. And any additional debridement. And this is, let me see if I can pause this when it's labeled. So this is, yeah, this is the right coronary annulus here, non-coronary sinus, and the annulus here. And this is the defect, or the aneurysm, outpouching from just under the valve. And this is where your pacemaker bundle of his passes through, probably over the crest here. And there's the mitral valve down here. Oh, that's painful. Let's see. All right, so I'll just let it play from here. And for this, I did pretty much similar style, took a bovine pericardial patch and sorted it. But I would have really liked some better imaging to plan this. So this you can usually just sew with your left hand too. That's the beauty of robot. You're not right-handed, you're ambidextrous surgeon. So just sew into that crest. I don't know if you guys can appreciate that. But with 3D vision with the robot, you can see really, really well, especially in areas that are very hard to see. And you can do septal myectomies. That would be, just not too far from that region. This is also C1 5-proline needle. And there's a very fine line trying to avoid a pacemaker versus making sure you have good enough of a bite. And the top edge of that patch was sewn to the annulus itself. And my valve bites went through that suture line. So for RAVR sutures, I put in just like I would in an open case. I usually start at the commissure between none and left, and then pretty much go clockwise. Here you can see the bites that are kind of like take the patch and the annulus at the same time. And once the sutures are in, I put in an onyx valve in this one, 46, secured with core knot.
The onyx valve is a taller valve.
Right.
Does that not increase the risk of coronary obstruction?
So it's the way it's designed is actually supposed to sit intraannular. So no, I've not had issues with that.
Yeah.
I've noticed that I agree with Dr. Ramchandani that it is a little bit more nuanced to implant
Right.
an onyx valve than it is a regular valve.
Especially you use pledgets, they get stuck under the frame.
Exactly.
It has to go inside the
It has
LVOT.
to coincide, so occasionally you end up having to settle for a slightly smaller size.
Yeah, the
Because
beauty.
you have to be intraannular as opposed to the supraannular position
Correct.
of any other valve. But the hemodynamics are great.
Right.
I mean, it's
Right.
my valve of choice for mechanical.
Right.
It's important because I think onyx, one not to use platinum to L, and the other is have the sutures go from LV to aorta. That's the essential features.
Right.
Yeah.
And one other thing is that the advertised sizes, they are not accurate whatsoever at all. Like a size 25 valve, end to end is over 30 millimeters. I think like 33 millimeters. So don't be fooled by the size of your annulus and say that if the annulus on CT scan measures like say 23, you will not be able to get a size 23 onyx valve in that patient. You have to do a root enlargement. So the good thing is, we do mechanical valves in younger patients. Their aortas are slightly more pliable, stretchable, but obviously you don't want to stretch too much to avoid mitral valve issues. So this is the largest series published on RAVR. It was, I think, presented at EX in 24. Very comparable outcomes to what you would find in any conventional open aortic valve registry or series. Thank you very much.
Thank you. Yeah.